I'm analyzing the family I had by showing which disorders each person in the family has and how their family dynamics may have contributed to the development of their disorders. First is Paris Lee Bennett. His disorders are conduct disorder, or CD, and antisocial personality disorder, or ASPD. His role is the scapegoat and the parentified child. First, we're going to be focusing on conduct disorder, which is a repetitive and persistent pattern of behavior in which basic rights of others or age-appropriate societal rules or norms are violated. At least 3 or more out of 15 criteria must be met for diagnosis, and the disturbance in behavior must cause significant impairment in social, occupational, or academic functioning. The criteria for CD that Paris meets are: he often bullies, intimidates, or threatens others. He has used a weapon that can cause serious harm to others. He has been physically cruel to people. He has forced someone into sexual activity, and he has deliberately destroyed others' property. Some other criteria of CD are often initiating physical fights, having been physically cruel to animals, having stolen while confronting a victim, having deliberately engaged in fire setting with the intention of causing serious damage, having broken into someone else's house, building, or car, conning others, having stolen items of non-trivial value without confronting a victim, often staying out at night despite parental prohibitions, has run away from home overnight at least twice while living in a parental or parental surrogate home, and is often truant from school. Researchers aren't exactly sure of what causes conduct disorder, but it's speculated to be a combination of genetic and environmental factors. The genetic factors are high testosterone, because that can be associated with aggression. Traumatic brain injuries, seizures, and neurological damage can also contribute to aggression. And certain characteristics of CD can be inherited, included antisocial behavior, impulsivity, temperament, aggression, and insensitivity to punishment. Environmental factors of CD include parents of children often having abused substances, engaging in antisocial behaviors, and they're often diagnosed with ADHD, a mood disorder, schizophrenia, or ASPD. A home environment that lacks structure and supervision with frequent conflicts between parents can also contribute by leading children to have maladaptive behaviors. Children exposed to frequent domestic violence are also more likely to develop CD, and low social and economic environments with overcrowding and unemployment may lead to a lack of adequate parenting. Availability of drugs and increased crime in a child's neighborhood also increases the risk of CD. Some potential treatments are parent management training, psychotherapy, anger management training, cognitive behavioral therapy, or community-based treatment, which includes therapeutic schools and residential treatment centered to reduce destructive behavior. And then this over here shows how to use CBT in daily life. Next up is ASPD, which is a pervasive pattern of disregard for and violation of the rights of others beginning by age 15 and is present in various contexts. At least 3 or more out of 7 clinical features must be met for diagnosis, and antisocial behavior must not be present exclusively during the course of schizophrenia or bipolar disorder. The clinical features Paris meets are failure to conform to social norms concerning lawful behaviors, irritability and aggressiveness, often with physical fights or assaults, reckless disregard for the safety of self or others, lack of remorse, and indifference to or rationalizing having hurt, mistreated, or stolen from another person. Other clinical features include deceitfulness, repeated lying, use of aliases, or conning others for pleasure or personal profit, inconsistent irresponsibility, failure to sustain consistent work behavior, or honor monetary obligations. There are multiple contributing factors to ASPD, including genetic, environmental, and neurodevelopmental factors. Genetic studies propose a hereditary component showing a 67% concordance rate in monozygotic twins and a 31% concordance rate in dizygotic twins. It's estimated that 20% of people with ASPD also have a first-degree relative with disorder. Serotonin can also play a role in impulsive and violent behaviors. Environmental factors can involve parenting styles. One study estimates that 14 to 21% of adults who report abusing their children have ASPD. Children who experience neglect or abuse may also be more predisposed to developing the disorder. Child and adolescent peer relations also impact peer personality development, with peer conflict identified as a key mechanism for future antisocial behavior. One neurodevelopmental factor is prefrontal dysfunction because it's associated with antisocial behavior and psychopathic traits. Medical conditions that damage neurons are also associated with personality disorders, and injury to the brain in utero from maternal drug use and maternal starvation has been proposed as a predisposing factor for antisocial behavior. Some potential treatments for ASPD include antidepressants, mood stabilizers, anticonvulsants, or antipsychotic medications. Psychotherapy may also be helpful, but there's little evidence of efficacy. This image shows how serotonin can affect impulsivity and aggression. Next up is Charity Lee Bennett. Her diagnoses are post-traumatic stress disorder, or PTSD, major depressive disorder, or MDD, and substance use disorder, or SUD. Her role in the family is the addict. Some criteria for PTSD include A. Exposure to actual or threatened death, serious injury, or serious violence in one or more ways. Directly experiencing the traumatic event, witnessing the event as it occurred in person, experiencing repeated or extreme exposure to aversive details of the traumatic event, which isn't applicable through exposure through media unless it's work-related, and learning the event occurred to a loved one. In cases of actual or threatened death, the event must have been violent or accidental. B. The presence of one or more of the following intrusion symptoms associated with the event beginning after the event occurred. 1. Recurrent involuntary and intrusive distressing memories of the event. 2. Recurrent distressing dreams in which the content or effect of the dream are related to the event. 3. Dissociative reactions in which the individual feels or acts as if the event were reoccurring. These reactions may occur on a continuum, with the most extreme expression being a complete loss of awareness or of present surroundings. 4. Intense or prolonged psychological distress at exposure to internal or external cues that symbolize or resemble an aspect of the event. 5. Marked physiological reactions to internal or external cues that symbolize or resemble an aspect of the event. C. Persistence, avoidance, or of stimuli associated with the event beginning after the event occurred, as evidenced by one or both of the following. 1. Avoidance of distressing memories, thoughts, or feelings about or closely associated with the event. 2. Avoidance of external reminders, which can be people, places, conversations, activities, objects, or situations that arouse distressing memories, thoughts, or feelings about or closely associated with the event. D. Negative alterations in cognitions and mood associated with the event beginning or worsening after the event occurred, as evidenced by two or more of the following. 1. Inability to remember an important aspect of the event, typically due to dissociative amnesia. 2. Persistent and exaggerated negative beliefs or expectations about oneself, others, or the world. 3. Persistent distorted cognitions about the cause or consequences of the event that lead to the individual to blame themselves or others. 4. Persistent negative emotional state. 5. Markedly diminished interest in significant activities. 6. Feelings of detachment or estrangement from others. 7. Persistent inability to experience positive emotions. E. Marked alterations in arousal and reactivity associated with the event beginning or worsening after the event occurred, as evidenced by two or more of the following. 1. Irritable behavior and angry outbursts, typically expressed as verbal or physical aggression toward people or objects. 2. Reckless or self-destructive behavior. 3. Hypervigilance. 4. Exaggerated startle response. 5. Problems with concentration. 6. Sleep disturbance. The duration of criteria B, C, D, and E must be more than 1 month. The disturbance must also cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The disturbance must also not be attributable to the physiological effects of a substance or medical condition. Potential treatments for PTSD include cognitive behavioral therapy, cognitive processing therapy, which is also known as CPT, and prolonged exposure, which is a specific type of CBT that teaches individuals to gradually approach trauma-related memories, feelings, and situations, therefore learning that the trauma-related memories and cues aren't dangerous and don't need to be avoided. And medications can also help, such as fluoxetine, paroxetine, and sertraline. Major depressive disorder is diagnosed when an individual has a persistently lower depressed mood, decreased interest in pleasurable activities, which is also known as anhedonia, feelings of guilt or worthlessness, lack of energy, poor concentration, appetite changes, psychomotor retardation or agitation, sleep disturbances, or suicidal thoughts. The individual must have 5 of the above-mentioned symptoms, of which one must be a depressed mood or anhedonia causing social or occupational impairment to be diagnosed with MDD. A history of manic or hypomanic episode must also be ruled out to make a diagnosis of MDD. Causes include biological, genetic, environmental, and psychosocial factors. While major depressive disorder was earlier considered to be mainly due to abnormalities in neurotransmitters, recent theories indicate that it's associated primarily with more complex neuroregulatory systems and neural circuits, causing secondary disturbances of neurotransmitter systems. GABA, glutamate, and glycine, all of which are neurotransmitters, as well as thyroid and growth hormone abnormalities, are found to play a role in the etiology of depression as well. Genetic studies show a very high concordance rate for twins to have MDD, particularly monozygotic twins. Environmental factors include life events and personality traits. Psychosocial factors include severe early stress that can result in drastic alterations in neuroendocrine and behavioral responses, which can cause structural changes in the cerebral cortex, leading to severe depression later in life. Some other causes are by the learned helplessness theory and the cognitive theory. The learned helplessness theory associates the occurrence of depression with experience of uncontrollable events, and cognitive theory states depression occurs as a result of cognitive distortions in people who are susceptible to depression. One potential treatment is the use of medications. SSRIs are usually the first line of treatment and the most widely prescribed antidepressants. SNRIs are often used for depressed patients with comorbid pain disorders. Atypical antidepressants are often prescribed as monotherapy or augmenting agents when patients develop sexual side effects due to SSRIs or SNRIs. MAOIs are not commonly used due to the high incidence of side effects and lethality in overdose, but they are sometimes prescribed. Other medications used for MDD include mood stabilizers, antipsychotics, serotonin modulators, and TCAs. Some other potential treatments are psychotherapies such as CBT and interpersonal therapy, electroconvulsive therapy, which is used for acute suicidality, severe depression during pregnancy, refusal to eat or drink, catatonia, and severe psychosis in major depressive disorder. Some other potential treatments are transcranial magnetic stimulation, which is used for patients who have failed at least one medication trial, and vagus nerve stimulation, which is used for patients who have failed at least 4 medication trials. Esketamine is also a nasal spray that is to be used in combination with an oral antidepressant for treatment-resistant patients in MDD. And this chart over here shows the depression prevalence by age group and sex. Next up is substance use disorder, which is a pattern of symptoms caused by using a substance that an individual continues taking despite its negative effects. There's 11 criteria in all, and there's 3 levels of severity. 2 to 3 criteria is mild, 4 to 5 criteria is moderate, and 6 or more criteria is severe, which signals an addiction. The criteria Charity meets are 1. Trying to cut down or stop using the substance but being unable to. 2. Experiencing intense cravings or urges to use the substance. 3. Neglecting responsibilities at home, work, or school because of the substance use. 4. Continuing to use even when it causes relationship problems. And 5. Continuing to use the substance despite it causing problems to your physical and mental health. Other criteria include 1. Using more of a substance than intended or using it for longer than you're meant to. 2. Needing more of the substance to get the desired effect, which is also known as tolerance. 3. Developing withdrawal symptoms when not using the substance. 4. Spending time getting and using drugs and recovering from the substance. 5. Giving up important or desirable social and recreational activities due to substance use. And 6. Using substances in risky settings that put you in danger. Some causes of substance use disorder are environmental, which can be the family's beliefs and attitudes towards drugs, and peer pressure can also contribute, as well as a lack of parental supervision. Genetic causes are predisposition to the disorder, like if a blood relative is addicted, and depression and PTSD can also contribute because some people use drugs as a coping mechanism, and highly addictive drugs used once, like opioids, can result in addiction faster. Some potential treatments for substance use disorder are using a less addictive drug as a replacement, like methadone or ketamine, attending a rehabilitation facility, and or psychotherapy. The next person I'm going to be focusing on is Kyla Bennett. Her diagnosis is antisocial personality disorder, and her role in the family is the narcissist. For ASPD, the criteria that Kyla meets are failure to conform to social norms concerning lawful behavior, such as performing acts that are grounds for arrest, which is evidenced by her potentially killing her husband. Another is deceitfulness, repeated lying, use of aliases, or conning others for pleasure or personal profit, which she admitted she manipulated the jury. Another one is reckless disregard for the safety of self or others, which she abandoned charity at 17 years old and only gave her $100 because of her addiction. And the last one is lack of remorse, indifference to, or rationalizing having hurt, mistreated, or stolen from another person. And this chart over here shows the prevalence of antisocial personality disorder by age group. So for family dynamics, I'll be explaining each of the roles and how each person fits it. The scapegoat is also known as the black sheep, and it's the person who's blamed for the family's problems and difficulties. This was depicted by Paris's aunt saying that Ella couldn't do anything wrong while Paris couldn't do anything right. This role may serve as a distraction from the family's problems. The parentified child is the caretaker of the family. This was depicted by Paris taking care of Ella when Charity was relapsing. The golden child is the favored child. They receive praise. They might have high expectations set for them, and or they might not be able to do anything wrong, like as seen by the parents. This role often masks the family's underlying issues. The addict is also known as the identified parent and is the person who is struggling with substance use disorder and exacerbates familial dysfunction. The narcissist doesn't necessarily have narcissistic personality disorder, but has narcissistic tendencies. They exhibit self-centered behavior and prioritize their own needs and desires over others. How their roles contribute to the disorder development. For Paris, being blamed for everything child may have led to his aggression, especially since he said that he was jealous of Ella. A lack of parental supervision can also lead to conduct disorder, which can also lead to ASPD. For Charity, Kyla's narcissistic tendencies may have led Charity's substance use disorder and major depressive disorder because she may have felt neglected and turned to drugs to cope with her depression. Kyla's antisocial personality disorder may have also caused Charity's post-traumatic stress disorder because she often had angry outbursts about her dead father, indicating that she may have had the disorder since she was a child.